inviting me. I do a lot of different things as a pediatric surgeon, and I do a lot of stuff, as you mentioned, fetal surgery, fetal medicine. But actually, one of my passions, kind of the one thing that a lot of people do, is deal with chest wall deformities. I don't know if anybody's had any kids they've dealt with that they've had a pectus deformity. I raise a hands. Know anybody seen it before? Yeah. So I actually was pretty surprised. It actually, I've been here about 10 years, and I started doing pectus surgery when I came. But we weren't really having that many kids come through. And then we started putting together a little program. It was really the only one sort of in this region of the country. And just kind of got the word out, and our clinic just kind of blew up. We see probably 15 to 20 kids every month. And it's probably about 12 to 15 new kids. And so I was actually pretty surprised, like how prevalent it is out there, and how a lot of families just don't really have a place to kind of go and get questions answered. And a lot of times they actually don't need any surgery. And I'll show you all this stuff here. And they just need a little bit of education just to make sure they're okay. But anyway, I thought I'd share a little bit about this with you a little bit. So we're going to talk about a couple of things. There's two forms of chest wall deformities: the ones that go in, the ones that come out. The ones that go in are called Pectus excavatum, and the ones that come out are the Cannatums. And we'll talk about the post-operative pain and sort of the hospital experience. The ones that go in are probably the more common ones. I would say it's probably 8 to 9 to 1 as opposed to ones that come out. And they're called Pectus excavatum. And folks refer to them as funnel chest or sunken chest. They come in all sorts of varieties. And sometimes kids are born with it, like this little baby up top. But sometimes they come and they develop a little bit later on in life. So we actually see them in sort of two age groups. It'll be a young mom that has her baby come in, newborn, they're born with it, and that's one group. And the other group is almost teenage kids that come in that they just started their growth spurt. And maybe parents hadn't seen the kid's chest in a while. They go to the pool this summer, and all of a sudden this kind of sunken in thing is there. And they kind of ignore it for a year, and then it starts getting bad and gets a little bit worse. And it kind of develops as they're going through puberty, and I'll try to explain to you why that sort of is. But they can be, pretty mild, where you don't really notice them, but just a little bit. Some of these are pretty severe and pretty obvious. And you can imagine for a kid growing up with something like this, they're not really doing stuff outside. They don't want to take their shirt off. They're not going to the pool. They're really kind of, if I had to draw a profile, they're not only not that engaged in athletics or even socially, because they're very socially aware of this. And even if they say that as a young age, they don't really care about it, by the time they get through puberty and get a little bit older, they start caring about it. So it's really kind of a big deal for kids growing up. Like I said, this is the most common form, the ones that go in. And boys are probably more affected than girls, although I see a fair amount of girls also. Statistically, it's not that common, 1 in 1,000, but it seems like in this region we see a lot of them. And there's probably a little bit of sort of demographic characteristics of this area that probably has a little bit more. But it is that we actually have a clinic now, a program around it, so people start coming from all over the place. There's all sorts of chest wall deformities, and I'll show you a few pictures of a few other ones. But the majority are these Pectus excavatums. There is a little bit of family history, but nobody really knows any genetics. I've got a few families that have siblings. Sometimes when you talk to the kids and their families, they've got an uncle or grandpa or even their dad might have had it. So it does kind of have probably a genetic component to it, but nobody really knows specifically what that is. I will say that no one knows specifically what the cause or why it sort of happened, but we know what the problem is. And the problem really isn't with the bones themselves, with the chest wall. It's really with the cartilage that connects the bones to the ribs and the sternum. So if you think that every rib probably has a cartilage that connects it to the sternum, and they should be relatively parallel, for some reason the kids with pectus, they don't actually grow that way, especially when they get supercharged and they start going through puberty. They, for some reason, the cartilage grows at either a different pace or a different angle than the ribs and the sternum. And so you actually may have a little bit offset. One will grow faster than the other, and it'll start dipping down or start pushing it out. And then sometimes this cartilage get fused. So if you went and did this surgery, the old-time surgery is that you actually remove the cartilage one at a time. But if you look at them, some of them are all stuck together. And it might be like 2 ribs to 1 piece of cartilage. It's pulling it one direction. And if you've got a few floating ribs down below, these kids usually have cartilage, like long connections of their cartilage to their sternum. So it's a cartilage problem, which makes it a good thing because we can, cartilage is more pliable and malleable and sort of moldable over time. Bones, you got to break them and let them heal. So that, so luckily we don't have to do that kind of stuff. But like I said, we see them in infancy. Sometimes they're born with it, but usually it's about right when they start to go through puberty. There's syndromes that go with it. There's Marfan's that I'm sure you guys know a lot about, and then Ehlers-Danlos, which is basically cartilage deformity problem. So there are syndromes with it. They come with really a whole variety of symptoms: shortness of breath, exercise intolerance. They lack endurance. Probably the kids that come when they hit puberty are ones saying, you know what, I can't keep up with my friends playing anymore. I get shorter breath. I used to run for miles. I used to be on the swim team, and now I can't really do it as much anymore. They can present with infections because their chest wall just doesn't expand and their lungs don't expand as well. And then they can have some heart problems, and I'll show you a little bit of the data around that. But a lot of times they'll come in and they really don't have any complaints. And whether or not they're telling you they don't have any physical complaints, but a lot of these kids don't do anything. Their favorite activity is probably their video game at home and stuff like that. Is because they just never put themselves in that position because they're always so self-conscious of their chest wall. I do have a lot of athletes that have come, and we'll talk a little bit about that. But really, body image and self-consciousness is a big thing. And so, I may see a kid, and they may test out, and we'll talk about the testing, function, pretty normal cardiac function. But you look at them, they're pretty self-conscious. They don't look at you in the eye. They, they don't interact with adults very well. Socially, they might be a little awkward. And then you fix their chest, and they come back in a year or 2 years, they're a completely different kid. They're engaging, they've done a lot of different things. They're playing soccer, they're going to the swim team, they're doing all these other things that they never did. And so I had this constant battle with the insurance companies, actually, because they always want to have all this documentation of symptomatic stuff before they are willing to pay for it. And so we argue with them a lot that, that these kids sometimes they don't put themselves in these positions because they're so self-conscious about it. And so for me, fixing this problem for kids about their self-consciousness and their body image is really very important to me too, which is why I offer this operation to some folks. It's a little bit complicated, but we kind of break them down into two groups: the ones that we consider severe, and I'll show you what severe means, and the ones that are sort of mild and moderate. If you're kind of mild and moderate, it's really not that bad. It's really about increasing your endurance, increasing your chest capacity, and there's exercise and other things that we sort of prescribe, and they work with our physical therapists and whatnot. And we see them every 6 months or so just to kind of follow up with them. If they already started puberty, if they've come in and they're 16, 17 years old already, chances are it's not going to change much. And so they can sort of, kind of live with that if they're okay with it. And but it's not going to get worse. If they come and they're like 10, 11, and they haven't quite hit puberty yet, chances are that it's going to change. And I always tell families I have never seen it change back to normal. It's always changed for the worse. So if they come with a pectus deformity, it's probably either going to be more deeper or more out, but it's never going to go real back to flat. But when we have kids that we consider sort of severe, and they're either severe because of the depth of the deformity, or through testing through their pulmonary function or their echo for cardiac function. And then those are the kids that we would offer operations to. So when they come to see me, they go through a pretty extensive evaluation. They get a history and physical exam, and we order kind of 4 series of tests, really. One's a CT scan of the chest, because we want to measure it for better or for worse, and I'll tell you why it's really not that great. They get an echo to look at cardiac function as well as an EKG, and then we put them through a pulmonary function test. And a lot of times they'll have a very restrictive pattern to their lung function, because the way we repair it is putting a bar in their chest. It's made out of alloys. We do allergy testing just to make sure, but it's pretty rare. By the time you're a teenager, you probably have been exposed to most everything and whatnot. And so here's a kiddo with a pectus deformity on a CT scan, and here's the heart in the middle. And there's not a lot of good ways of measuring it. And so the one thing that we do have now is this thing called a Haller index. And all it is really a ratio of measuring across and then measuring it up and down. And then we divide the two, so A divided by B, essentially. And anything greater than 3.25 is what we consider severe. And if the insurance company sees something greater than 3.25, we usually don't have them. They're not going to usually push back on it, okay? And we know from data that those that are in the severe category would probably benefit the most from having an operation to fix it. And I'll show you how we fix it here. But the Haller index isn't perfect, but it's all we got right now. Because here's 2 Haller indexes. Here's clearly a kid, right, that has a pectus deformity. It's not that bad, but when you measure it out, it's not in the severe category. But I think that any person that looks at this could say, hey, this is a pectus deformity, right? But here's a kid that has a normal CT of their chest, right? There's no pectus deformity out. And when you measure it out, actually the Haller index is in the severe category. And so the wider you are, the higher Haller index is going to be. So sometimes you'll see a small kid, they're pretty deep, they don't measure out very high, so you got to make this judgment call whether or not it works or not. So, you know, this is more for sort of our medical decision making, but it's to show you that not all pectuses are built the same. When we look at pulmonary function tests, they usually have a decreased FEV1, and so their ability to expel air quickly is fairly limited. And if you look at this chart's a little confusing, but it's really about the percentage of FEV1. If this is sort of before an operation, and if you measured all the kids that had a pectus operation, you can see that there actually shifts everything to the right a little bit after an operation, so their lungs can expand. And it really has to do with the dynamics of the lung function. So when we look at the dynamics of the chest movement with a pectus, the way I tell families is that if it's kind of sinking in and it's down like this, there's a bit of a hinge effect. And you can expand all you want, but you're not going to pop that sternum up. You'll never, because there's no hinge there. So you're actually limited by the angle of your chest. So if we measured the movement of the chest sort of at the top and then at the nipple line, the xiphoid and the costal margin, you can see that they actually have decreased movement, 51% decrease, 46%, 48, 28, 21%. So compared to what you normally would be able to do when you expand your chest, they actually can't flex their chest open as much. That's why they're sort of restrictive like that. After you fix them though, and we see them long term, you can see that their compliance in their chest is actually much better. So, you know, you may not get that much volume in their chest cavity as far as their breathing capacity, but now their ability to really flex and really expand when they need it is really altered. And so after surgery, you know, this is 100% of what it was, 112%. This was about double, this was 28% before. And so there's incremental increases after an operation. Cardiac function is also kind of hit and miss on how kids are affected. So here's a CT, pectus deformity, pretty obviously sinking down. This heart looks pretty much intact, but it's kind of pushed over a little bit, okay? So this echocardiogram will probably be relatively normal. Here's a pectus deformity that you can see that the right ventricle on this whole side is kind of squished down. And so they have no capacity to expand their stroke volume when they're exercising, doing things like that. And so it can be pretty restrictive. If I look at an MRI here, you can see here's the right ventricle, and it's, you know, it should be kind of like this, where it kind of fills and it's kind of round. Like this whole right ventricle here is just squished, and there's just no capacity for it to expand because of it. Here's an echo. An echo here, here's a left ventricle that's relatively open, that's filled, and here's one that's all slendered down because it's getting pressed down by the sternum. So it can affect kids' cardiac function. Probably their most common defect, if you look at an echo, is this left ventricular compression and also a little bit of mitral valve prolapse. And so they actually don't get the stroke volume that they should be getting if they have their chest sort of compressed down. As I mentioned, sort of mild to moderate is really about exercise and posture, about doing the best you can to expand your chest. And the severe ones really go through this whole progression, and we talk about surgery. I'm going to skip a little bit here. And so we actually do an operation on these kids where we actually elevate their chest with a bar underneath it. I'm going to show you some videos and pictures here in a little bit. And the ideal time for this is really about 10 to 14 years of age. When they're actually kind of ready to go through puberty. Because what we want is we want to correct their chest at a point where it's still soft, where it's compliable and pressable, But as they go through puberty and their bones and their cartilage hardens, it gets fixed in place because that bar is temporary. It only stays in for about 3 years. When they're kind of in this younger age and their chest is softer, their recovery is a little bit better. It's not as a dynamic kind of crazy thing about popping their chest out. But I also do some adults that come and see me, so 30, 40-year-olds. And if I put them on a scale of uncomfortable and whininess after an operation, I'd rather do the 10 to 12-year-old than the 35-year-old. Yeah, those guys are, they're something else. The worst part is they got to get admitted to the children's hospital. And so there's the children's hospital is completely not geared to adults. And so they'll be complaining about this and all that. And now here the child life person comes in with their toys and all this stuff, try to make them feel better. But I get it. It affects a lot of people, and we do offer it to adults too. But it's definitely a different patient population. The old way of doing it is really an operation. We actually removed all the cartilage, so they get this big whack, sternotomy down the middle, or at least through the skin, and you take their pectus off their chest, their pec muscles, and you get to their cartilage. And the cartilage itself has a perichondrium to it, and that's what actually is the growth. So you slice it open and actually carve out the cartilage, and then you leave the lining, sew it back, and it'll grow back, but now hopefully it's in a flatter position. And so you can imagine it's just the rows of cartilage. You got to take them all down. And so for about 6 months, they have this sort of free-floating sternum. So, they wear a protective shield and kind of all this. And it's a big operation, and sometimes we still have to do it. You don't plan for lunch when you do one of those operations. But luckily, we don't really have to do that much anymore. So the operation of choice now is what we call a minimally invasive NUS repair. And it's really about putting this bar in someone's chest. It's a titanium alloy, mixed alloy bar. And it basically sits under the sternum. It goes in from one side outside the chest and goes underneath it. And this has sort of been the sort of operation of choice for the last 20 or 30 years. And we do it with little cameras and whatnot. We make a couple incisions on the side. We put a camera in the chest because we actually have to tunnel the space between the sternum and the heart. That's not a natural space there. And so we obviously don't want to stick the bar through the heart. That would not be good for anybody, especially the patient. But the space is pretty tight. Okay, it's not really a real space. And so you kind of got to create this space with this beating heart underneath it. And then you got to shove this bar and rod through it and then get the thing elevated. And the bar sits underneath the sternum. So it kind of goes on the outside of the chest. There's an incision here. We make a little tiny incision here just to kind of lift the chest up. But it goes into the chest, under the sternum, outside the chest, and sort of sits out here. Seeing pictures here in a second. We drive it through with this wand that goes through the space underneath the chest because we've got to bring it through. So here's what it looks like. So here's this pectus deformity. We make a little incision, get underneath here, be able to kind of pull this all the way through, and then we drag the bar back around again, just sort of elevate it. And then at the end, it looks just like this model. It's perfect, just like this, just like God meant it to be, all right? There are some complications. Early ones, we get pneumothorax, we get air in the lung, which usually goes away. They could get some fluid in the chest cavity, and they can get infections like a pericarditis or something like that. Infections and allergies to the bars are really late complications, so those are kind of things that we'd like to stay away from. And so here's a 15-year-old, pretty severe pectus deformity in the operating room. I'll be able to play here in a second. You can see it's long. His sternum, it probably ends about right here, but it's a pretty severe pectus deformity. Let's see if we can play this. This is after we've done a lot of the work and ready to pull the bar through the chest again. And so we've made the tunnel, we've made this pathway here. Here's the bar in my hand, and we're going to shove this thing through his chest and bring it through the other side over here. Have you guys had lunch yet? No, not yet. So we take this kid that's had this for most of his life, 15 years, in about an hour and a half. We kind of flip his chest flat. So you can imagine how painful that's got to be for these kids. But you come back in 6 months and every one of them says it's worth doing. They suffer through it a little bit, and the families suffer through it. I'll show you here in a second. Here's the other one. I couldn't get them all together. So now we got the bar all the way through. It's pointing up. We're going to flip it down, and now here it is. We tug on a little bit. We adjust a little bit left and right. We got to tweak the ends a little bit just to get them. But now it's completely flat. They get a little bit of rib flaring at the end because the cartilage is still attached, so it's a little bit abnormal still.
Can we take the rolls off of his back?
But there it is, hour and a half, 2 hours, something like that. So here's a kid. This is this kid right here. So you see he's got a big old bar here. Got a little stabilizer here to hold it in place. Sometimes you got to put 2 bars in if they're really big, if they've got certain conditions. But it's pretty big. But if you look at him 3 years later, here's a Pectus kid, pretty flat. That looks pretty good. Here's a kid that I usually put a little betadine just to show how deep and how wide it is. So here's a kid that we did earlier this summer at the end of the operation. He's pretty flat, 3 little incisions like that. He had 2 bars in. You can't really even tell he had 2 bars at all. So it's pretty good. So what to expect after surgery? They're hurting pretty good, as you imagine. They get a whole combination. We've got our pediatric anesthesia that really sees them and does a lot of great things. We try to stay away from as much narcotics as we can. And so one of the things I started doing about a year ago was actually sort of this thing that I don't think a lot of people do. And it's called cryoanalgesia. And so we take this probe actually, and the nerves for the chest are under the ribs, and they go under the ribs. And what we do is actually freeze the ribs, freeze the nerves. And actually what it does is that if this is a nerve sheath right here and the axons are the ones that fire the pain, you actually take this and you freeze it with nitric oxide to about -65, and you sort of kill that nerve there for about 6 months. And so that has been dramatically changed how kids recover from this operation. And right underneath the ribs, and you can see all it is a little bit of bruising, but it actually denervates their pain. And to the point that before I started doing these, the kids were in the hospital about 5 days. They looked really miserable. Even when they went home, they were sort of just not really being very active, and they couldn't really do anything. They took a lot of narcotics when they went home. But when we started doing this thing, like they were out of the hospital like 2 days, 3 days, and they're sitting up talking to you. They're texting their friends on their phone, talking to their girlfriend. They're like almost back to normal. And so their recovery has speeded up dramatically because we started doing this. And I don't think a lot of people is doing this in the country, but it'll start happening because I think the results are pretty dramatic. And it's really been a great thing for our kids because that's the one thing that I tell them. You can't explain to them how painful it is. And so I'm afraid the adults are going to find out about this and they're going to get more adult referrals. And I'm not sure I want to tell them about it. So I tell families they're in the hospital about 3 to 5 days. Traditionally, it was about 5 to 7, but now they're getting to about 3 because we're doing this cryoanesthesia thing. And then it's probably about slow recovery for about 6 weeks, meaning they're not doing much, they're at home. I tell them to do a lot of stretching and whatnot. And, traditionally, it takes about 6 months for them to say, I'm just not even thinking about it. I'm doing everything. I know I have this bar in, but it doesn't hurt, it doesn't tweak. I'm sleeping on my side, I'm sleeping on my back, whatever I used to do. I'm doing sports and all that kind of stuff. I tell the kids they can go back to activity, physical activity, as soon as they sort of feel like it, when they're off all their meds and whatnot. And I've got kids that play basketball competitively. I got kids that weight lift. I got kids that snowboard, do all these other things. And they're back doing this stuff really about 6 months. I haven't had any kids ask me to play football yet, and I'm a little reluctant to clear them to play football because it's a freaking bar in their chest, So I don't know. If you guys had somebody you want to play football, then let me know. We got to figure that one out. But they go through airports with a bar. That's all that's fine. But it takes a while for them to recover, but they do. And the bar stays in for about 3 years, and we take it out as an outpatient surgery, and it flies by, and they do really great. So I won't talk about Cannatums too much. These are pigeon chests. They're actually very not symptomatic. It's really mostly cosmetic. And I'll just tell you that we fix these things with a brace. And even the ones now are pretty light and compact. You can't even tell them when you're wearing a shirt. And it takes about 20 months for them to work. If you come to me when they're pretty young, pre-pubescent, You put them in a brace, it'll fix it, and they don't need to have surgery anymore. If they're older, they're already gone through puberty, that's a kind of different story. But as soon as they come, put them in a brace, they wear it, it actually works out pretty good. So, and then you got great kids like this. This is a kid from 2 summers ago that used to text me pictures of him eating cereal out of his chest. So, so that's a little bit of Pectus. Hopefully you guys don't have too many kids that you know, but you know, it's something that I don't do during the school year because it really puts them out for a while. So we see them throughout the year, and I try to push them towards summer, early summer. So we're really busy now doing a lot of Pectus surgery. Hopefully they recover enough to go back to school. But anyway, hope this gives you a little idea of this little condition you guys might run into. So I have to answer any questions.
Any questions?
Yeah.
Hopefully he doesn't ever experience a cardiac emergency, but you know, CPR they go on normal.
Yeah, they go on normal. And the only thing about doing CPR on these kids is you got to do it from below. So you can do it. You're not going to be able to do chest compressions, but you're going to have to do it through the diaphragm. And I think that's relatively okay. And these kids, when we see them, we actually hook them up with a patient ID like bracelet. Sometimes they want a bracelet. Sometimes the girls want a necklace. They have something in their wallet, and they have a letter with them when they travel. Say, I got a freaking bar in my chest. Please don't pound on me. You know. So, but that's a good question. Though. Yeah. Yeah. Was there another question? No, it doesn't conduct. It's a mixed alloy, so it should be okay. Yeah. If you ever run into it, you'll see they've got 2 incisions. You'll feel it. You can feel the bar on the edge. You won't feel it in the middle because it's under the sternum, but you'll feel it on the side. So if you're more comfortable, just put it away from the bar, but it shouldn't conduct. So
Basketball can be, you know, a contact sport.
Yeah.
So do they wear extra protection? You know, because I know you said football, you would worry about this, but
Yeah.
basketball can be some less sometimes. So.
yeah, so I got a couple of kids that play AAU, and one kid wanted to have his surgery done during the school year, so he wouldn't miss summer AAU. And his parents were okay with that for some reason. But they wear a little flak jacket. And I think that once that sort of heals, you know, the bar's there. I think if you pounded on it, it would probably hurt a little bit because it rubbed up against muscle. But they don't have to wear anything too much. They got, you know, those kind of compression tights with little padding. I think that's probably good enough. So, yeah.
Generally, when you do surgery on these kids with pre-existing heart condition as well, does the heart condition generally change or heal up after that?
Yeah, it gets better. So their stroke volume increases. Sometimes the mitral valve prolapse may not get better, but you can see that if you echo them afterwards, their right ventricle is now expanded. And so they still got to push themselves and exercise, you know.